So hi everyone, I'm really excited to be able to share with you today the work we've been doing at Congenica in providing a rapid exome sequencing service for patients with complex rare disease. Before we begin, I'd like to introduce myself. I sit within the Congenica clinical team as a practicing state-registered clinical scientist. I've previously worked within the NHS and undertook my specialist training at a major regional genetics centre in London. I'm a member of the BSGM and a former chair of the London Healthcare Scientist Trainee Network. I have a specialist interest in neurodevelopmental disorders and epilepsy. As a team, we've worked collaboratively with a number of institutions that also specialise in this area, so Future Neuro and the Institute of Basic Research, just to name a few. I also have an interest in reproductive and prenatal genomics. I was due to present some of this work actually at ACMG in March in San Antonio, but unfortunately due to the current situation, this was cancelled. The good news is that I believe an online version of that content should be available also later this year. So before we begin, Congenica is a digital health company helping healthcare professionals and organizations to rapidly turn complex genomic data into clinically relevant insights that support diagnosis and clinical decision-making. Perhaps some of you might already be aware, but Congenica has developed a clinical decision support platform for the analysis and interpretation of NGS panels, exomes, and whole genomes. Although we're a relatively young business, Congenica has a growing global base of collaborators and customers, including diagnostic labs, research centres, and national genomic programmes. Of particular note is our partnership with Genomics England in the 100,000 Genomes Project for rare diseases, as well as the NHS in the rollout of genomic medicine service to the entire UK health system. In terms of an outline for today, I really want to begin by outlining the value of exome sequencing as a diagnostic approach for patients with complex rare disease. I'll then move on to discussing the rapid exome sequencing service we've developed, with a particular focus on some real-life case studies. So to begin, what is the value of exome sequencing? Well, in recent years, exome sequencing has been consistently shown to improve the diagnostic yield when used as an approach to diagnose children with suspected monogenic disease. I'd like to draw your attention in particular to, as I'm showing on the slide, this paper from a few years ago by Dylan et al., who found that in a cohort of children with suspected monogenic disease, 23% of the patients that they considered diagnosed by whole exome sequencing would have gone undiagnosed by a panel approach. The value of exome sequencing in achieving a higher diagnostic yield for these patients is likely to be even higher if you can incorporate a copy number variant element, which we're able to do using our pipeline, and I'll discuss this in much greater detail later on in the presentation. Incorporating a copy number element potentially eliminates the need for array CGH, MLPA, or some other assessment of copy number status to be performed. And clearly, a number of children, particularly with neurodevelopmental disorders, will have a structural imbalance rather than a single nucleotide variant or small indel, such like. So, there are over 1,500 loci known to be associated with neurodevelopmental disorders, and the mode of inheritance can be recessive, dominant, X-linked, and is also complicated by complex inheritance patterns and the effect that the environment may play. The genes identified to be associated with epilepsy grow almost daily. In particular, if we think about epilepsy as a subset of those neurodevelopmental disorders. And it's now recognized that for these conditions, a single phenotype can be caused by several different genes. It's also recognized that variants in a single gene can bring about several different phenotypes, making it really difficult for a clinician to pinpoint a single gene for any given phenotype. And what this does is it really illustrates the need to stratify the causes further with better genomic understanding for these conditions, but also the need for a diagnostic pathway to reflect this high heterogeneity. And this is where exome sequencing is clearly a good fit. So if we step back a little bit and think about, in particular, so as I've been talking about neurodevelopmental disorders, for children presenting with a neurodevelopmental disorder, the referring clinician will often use a battery of different diagnostic tests, including both genetic and non-genetic analyses. A multidisciplinary, so an MDT approach is clearly needed, involving both clinical and scientific professionals. Genetic testing strategies often include analysis of whole chromosomes using, as I've mentioned earlier in the presentation, chromosomal microarray, or sequencing via a gene panel approach. And it can take over 6 months to achieve a diagnosis, and so it can take over 6 months, to undertake this diagnostic process. And at the end, a diagnosis may still not be achieved if the causal gene or mechanism of action is missing from the analysis undertaken. And if we think about the reasons why there's such a diagnostic odyssey for these patients and why they're often left without a diagnosis, the reasons are really, as I'm showing on the slide here, numerous and quite complex. To put it simply, the tests just aren't comprehensive enough to pick up every diagnosis, either because they don't consider the gene of interest or the appropriate mechanism of action. So why is a different testing strategy not being adopted? Well, resource allocation can often be an issue. So physicians and scientists don't have unlimited time and money to spend searching for a diagnosis in every single patient by performing more and more sequential testing. And it's therefore there are also often considerations around funding. So what testing is funded in different healthcare systems for these patients. And it can also be hard for physicians and scientists to find time to keep up to date in terms of gene discovery and the general diagnostic field. And as I've stated here, it's really a hugely fast-paced area of medicine. So you can imagine that it may be hard to consider how one would even begin to extend the testing beyond what is standard, because you wouldn't know how to interpret the findings, even if you were able to do the testing. Overall, I just think there may be a lack of understanding of the benefit of testing beyond that which has been in place for some time as the standard and the routine. So until quite recently, that was the limit of the analysis available to these patients. And you can think about the impact of that lengthy diagnostic process with no result at the end, which is clearly harmful for patients, their families, and the healthcare professionals that treat them. So it's really costly and frustrating, and it leaves patients and their families with little information about recurrence risk or perhaps signposting to appropriate treatment or care and support. So I'm just showing on the slide there, anxiety, worry, and then obviously considerations around restricted personal care and thinking about support groups, and even in some cases, treatment efficacy and adverse effects. So as I said at the beginning of this introduction to the topic, the diagnostic yield using exome sequencing in a postnatal setting has been consistently shown to improve the diagnostic yield in these patients. So you can see on the slide here just one example of a study from a few years ago where the yield they found was about 40%. So what I now wanted to do was just touch briefly on exome sequencing in the prenatal setting rather than the postnatal, as I've just been talking about. So as a bit of a background, we know that fetal ultrasound detects anomalies in about 2 to 5% of pregnancies. And these abnormalities can range from isolated minor abnormalities to those that may involve multiple systems and be much more severe. And of the roughly 4,000 monogenic diseases, we know at least 200 of them have a prenatal manifestation. And that list is constantly growing as our understanding improves and our learning in this area increases. But what we do know already is that genetic disorders are a leading cause of morbidity and premature death in the prenatal and neonatal period. So when a case has an underlying genetic diagnosis, it's really, really important that they're identified to allow for that accurate management. And diagnosis is clearly also important in terms of enabling reproductive decision-making and also assessment of recurrence risk for patients. So as I'm showing here, current testing strategies are only about able to achieve a genetic diagnosis in around 40% of cases. But we know that the real figure is likely to be much higher than that. So there will be a subset of that 60% undiagnosed who do have a genetic abnormality. It's just that we can't detect it using the methods that we have in place at present. And when I think about, current testing strategies, what I'm considering here is QF-PCR, perhaps a G-banded karyotype, and of course microarray, and there will no doubt be other standard testing protocols that are in place. So the yield for exome sequencing clearly varies in both the pre and the postnatal setting, depending on the patient selection. And when we think about the prenatal setting, the pregnancy cohort that we're looking at. So some studies, however, have suggested a yield of up to 80%, which I'm showing on the slide here, but so others have found it to be much lower. But what I now wanted to do is just focus on the exome service that we provide here at Congenica. And in particular, I wanted to highlight for you some complex cases that we've used exome sequencing to resolve. So we've been running this exome service for around 2 years, and we've analysed over 600 cases, and those are both postnatal and prenatal. This has all been done in conjunction with St George's Hospital in South London, amongst other customers, for want of a better word. And I wanted to particularly focus on St George's Hospital here, however, because the cases that I'll show later on in this presentation were all referred by them. But as I'm showing here on the slide, so the pipeline that we use incorporates a copy number testing element, and it's really fantastic to be able to offer this single comprehensive test. We've achieved this in conjunction with our colleagues at Nonicus in developing the Exome CG assay, which allows for this assessment of exome depth. On the slide here, I've illustrated the steps that I would consider to be owned by Congenica, if you like. And when I say Congenica, I refer both to the platform itself and the underlying bioinformatic pipeline, but also the clinical interpretation that myself and my colleagues within our clinical and scientific team that we perform. A few key features to highlight would be, as I've said, the copy number aspect by Exome CG and Exome Depth, but also the variant prioritization capabilities by Exomizer, as well as comprehensive reference data in the form of Decipher, ClinVar. We also have Mastermind integrated within the product, which is a fantastic variant level literature searching tool. And if we think about, so what kind of results are we getting? Well, you can see that the vast majority of those, so 634 cases, are postnatal, but we do, as I've said, offer a rapid service for prenatal cases. And our diagnostic yield across the patient groups, across the postnatal prenatal setting, sits at 23%. In terms of a variant interpretation approach, I don't have time to talk about that extensively today, but I just wanted to touch on it quickly, is we do use ACMG guidelines, and we consider standard lines of evidence when performing our interpretations, such as functional studies and segregation information. However, what I really wanted to point out today is that we have a really unique setup with St George's, and that we have an extremely collaborative and close working relationship with the physicians and the whole care team. And as such, we have a real depth of phenotypic information at our disposal. And I think this has benefited us hugely and allowed for the upgrading or downgrading of variants of uncertain significance in many, many cases. So we certainly feel it's truly worth, if possible, investing in a truly multidisciplinary approach. Just to say, we do report variants of uncertain significance, and clearly they can represent, for want of a better word, a burden in some ways. So wherever possible, it's good to be able to review those and resolve them either way. I won't be talking directly anymore about the Congenica platform and its capabilities, but some of the cases do show some aspects of what a powerful tool it is in helping us to solve these complex and often challenging cases. So what I'm showing here is a breakdown of the yield for postnatal cases, which stands at 21%. On a previous slide, I showed that some studies have seen a yield of about 40%. However, it's important to note that the yield, as I've said, will vary depending upon the cohort selected. And we don't gatekeep our referrals as such, so we see a wide range of phenotypes, not just neurodevelopmental disorders. However, the pie chart to the right is showing that the vast majority of our referrals are in patients with developmental disorders. And to the left, you'll see, hopefully it's clear enough on the slides, to the left you will see the diagnostic yield in this phenotypic group, so in the neurodevelopmental disorders, compared to other phenotypic groups, is the highest. Both figures also give you an idea of the breadth of referrals we see. So we see everything from cardiac referrals to endocrine and absolutely everything in between. So, and just a final note to say that we do see mostly trios. So we do see, but we will take other family structures. So singletons and situations where you have affected siblings. Yeah. handle all of those. So what I now wanted to do was just to move to discussing an interesting postnatal case with you. So this was a patient, a 13-year-old girl, referred to us for investigation of developmental delay and an epilepsy phenotype. She also has a similarly affected sibling. A huge amount of testing had been undertaken prior to this exome, including enrollment in multiple large-scale sequencing studies, such as the 100,000 Genomes Project here in the UK. But none of this testing had managed to find a cause for this particular child's condition. So using the Congenica platform, we were able to detect one maternally inherited missense variant, but arguably more interestingly, one paternally inherited synonymous variant that is predicted to create a cryptic splice site in the ALG11 gene. So the phenotype of ALG11 there, which is a congenital disorder of glycosylation, the phenotype is a good fit for both of the affected siblings. So there are, we believe, two reasons why this finding was not detected using any of the other sequencing approaches that had been performed. Well, firstly, the biochemical screening, so the normal biochemical screening result that the patient had doesn't fit with the finding of ALG11. Hence, we feel that it's possible that this particular disorder, or the possibility of this disorder, was not flagged up for the clinician or care team. And this really highlights the challenge clinicians are faced with around genotype-phenotype relationships and the fit of them, as I touched on in the introduction to this. And secondly, the synonymous variant was filtered out by other bioinformatics pipelines. The Congenica splicing annotation capabilities, which are very powerful, plus the ability for us to really easily see segregation data, which showed the variant was shared between the affected siblings and that it was paternally inherited, really brought this variant to our attention. So if we think about what the outcome here was, well, follow-up testing of the patient showed shortened ALG transcripts. Although splicing in this particular gene is actually quite difficult to interpret. And digging a little bit deeper into the literature showed that normal biochemical screening is actually often seen in ALG11. So that fits with the normal isoelectric focusing of transferrin seen in both siblings that I mentioned earlier. Further testing is now in progress to look for reduction of protein levels. However, the HPLC and the thin layer chromatography has already shown truncated sugar structures in both of the girls. So the finding was of great relief to the family, and we really do hope to soon be definitively able to end the diagnostic odyssey for them once that follow-up testing is complete. So if we now focus our attention to the prenatal work that we've been doing. So as I said, the majority of our referrals are postnatal, but in that prenatal group, the majority of our referrals have actually been from pregnancies with multiple congenital anomalies, with skeletal dysplasias giving the highest yield of any phenotypic group, and that figure sits at around 69%, as you can see in the graph to the left. So really high. And we accept all family structures, as I said. However, the majority of our cases are trios. Trio testing, as just to touch on it a little bit further, we know that it's not always feasible or appropriate for some families. However, having parental information is really useful in terms of the efficiency gains to be had when looking at the mode of inheritance for a variant. And clearly, when you don't have parental samples, you can't determine if a variant's de novo. And this can really be an important piece of evidence when assigning pathogenicity. And we do find that in many cases, this information about the de novo status is the difference between a variant of uncertain significance and a pathogenic assessment. I wanted to highlight the point as well that as with postnatal reports, we do report variants of uncertain significance, and some may argue that the variant of uncertain significance burden here is even higher in some ways. So good to be able to remove that where at all possible. So of the 120 cases that we've tested, we're getting an overall yield of about 31%. And this includes 2 cases where we've identified a CNV of clinical significance, so one of those copy number variants. It's clearly fantastic in terms of efficiency, so thinking about time and money saving to be able to detect CNVs and the SNVs and indels in tandem. So onto my second case study, and this is a prenatal referral. So this was a referral from an unrelated couple who'd had one previous healthy child, but also a history of miscarriages. And by the 20-week scan, short femurs were present and a suspected fracture, although calcification of the skull was actually normal. By 33 weeks, however, bowing of the right femur was present and there was evidence of further fractures. So there was clearly a query at this stage of whether this was an osteogenesis imperfecta. So what we did is we undertook singleton exome sequencing in this instance, focusing on the osteogenesis imperfecta gene panel from Panlab, which is a Genomics England curation resource. If any of you haven't accessed Panlab before, I would really urge you to go and take a look at it after today, as it's a really fantastic resource and we do rely on, well, not rely on it, we use it quite heavily along with our own kind of assessment manual gene curation effort. But yeah, really fantastic resource. So what we found is two variants in the ALPL gene, one missense and one splicing. And the splicing variants predicted to impact the nearby donor site. This particular splicing variant has been described in multiple affected patients, with one homozygous case being lethal. The missense variant had been described in the compound het state in multiple patients, but this, as I said, this was a singleton case, but without parental samples, it was really hard for us to call these variants anything other than of uncertain significance. Now, ALPL is associated with defective mineralization of bone and teeth in the presence of low activity of serum and bone alkaline phosphatase, and both dominant and recessive modes of inheritance have been described. So what we did is we followed this testing up with parental studies to give us both segregation data, but also looking at the biochemical result of these in the parents. Testing is unreliable in pregnant women, but the father was found to have a low ALP, which is clearly consistent with the findings, as carriers would also be predicted to have low ALP. This finding actually gave a much better prognosis than osteogenesis imperfecta, and the pregnancy continued with the right care in place to support the family. If we think about postnatal management, so postnatal metabolic assessment was performed and confirmed a diagnosis of infantile hypophosphatasia, and the skeletal survey showed hypomineralization. The baby was started on enzyme replacement therapy, and it's clearly fantastic when you have a finding like this that directly impacts the management, in this case in such a positive way, we feel. The couple themselves could then have follow-up about recurrence risk, but also appropriate management, as carriers themselves may develop symptoms. So overall, this was a really fantastic result for this family from what started out as some pretty tough scans. For the final case, I wanted to discuss a prenatal test where we detected both a copy number variant and a single nucleotide variant in parallel. So if we think about the standard sequential testing pathway in a prenatal setting for a moment, there are really two scenarios. So firstly, you may have a microarray or other copy number assessment may be performed and give a negative result, which then prompts an assessment by exome or other NGS testing to look for single nucleotide variants. Secondly, you may have an exome performed that doesn't have a copy number assessment element to it. And the exome detects a single SNV, so a single hit, if you like, in a recessive condition. And what you would then have to do is follow this up with MLPA or some other copy number testing to search for the second hit. And both of these approaches are timely, and clearly in a prenatal referral, this is time sensitive. And there's also a cost implication. So being able to provide a single test is something that we're really, really excited about being able to do. So this was a case referred at 20 weeks with multiple abnormalities, but primarily this was a hydropic picture. You can see from the scans I'm showing on the slide here, the bright bowel and pleural effusions to the left, and the raised nuchal on the right. And there was also some right ventricular brightness and hypertrophy as well, which I haven't got the scan up there. So what we found is we detected both a maternally inherited frameshift variant and a paternally inherited copy number loss in the SUMF1 gene. Now, SUMF1 is associated with autosomal recessive multiple sulfatase deficiency. And you can see on the slide just a snapshot of the Congenica integrated genome browser where we actually perform our interpretation and analysis. So just to give you an idea of how that looks, pulling in the functional and reference data amongst other information to come to that pathogenicity conclusion. Cases of severe neonatal multiple sulfatase deficiency presenting in the, with high drops in the prenatal period have been described. Another important point for this case was we were made aware that array CGH testing actually hadn't detected this copy number loss. The copy number loss was about 69 kilobases in size, so while we aren't able to say definitively, what this may be suggesting is that exome sequencing can detect copy number variants that microarray can't. What I've also shown on the slide here is the turnaround time of 20 days from sample receipt to report. And this is really reflective of our standard turnaround time. So I don't have a slide on this, but actually I just wanted to talk about another case that we had that we detected both a pathogenic SNV and CNV. Again, both inherited from an unaffected parent in the RBM8A gene. And this was a fetus with a skeletal dysplasia phenotype, including a short humerus and abnormalities of the right arm. And we found the well-characterized 5' UTR variant associated with thrombocytopenia absent radius syndrome, associated with a copy number loss of about, I think it was about 400 kilobases that encompassed the RBM8A gene. And in this case, we later found consistency with the array findings, so the array was able to detect the loss. However, the point I was making about illustrating this case was that that case also had a 20-day turnaround time. So this is fairly reflective of the time we're managing to meet for the St. George's prenatal referrals, and we're really proud of that in terms of offering management time in a timely manner for these patients. So to conclude, I hope today I've given an insight into the challenge of diagnosing rare disease patients and how exome sequencing can be of benefit to balance cost, clinical utility, and diagnostic yield. I really hope the case studies I've presented have been of interest to you. I think they highlight the challenges of phenotype-genotype correlations in rare disease, amongst other challenges. But mainly, I really hope that they show how exome sequencing is already being used clinically to end the diagnostic odyssey and benefit patients with rare disease. So just a big thank you to my clinical colleagues at St. George's, as I said, whose cases these were, and the scientific colleagues that we have there who help us with this work. And in particular to my colleagues at Congenica, without whom this testing would not be possible. So if you'd like to find more about the work that we do and what we do, or further information about the Congenica platform in general and how we might work with you, please do get in touch. The contact details are there on the slide. And I'm also always really happy to take questions directly as well. So thank you so much for your time today. It's been a real pleasure to be able to show this work to you.